Hello and welcome to our ACLP Symposium, Controversies in Psychiatric Emergency Room Management. My name is John Taylor, and I'm going to introduce our symposium and our other speakers. My name is John Taylor. I'm the lead medical director for Author Care. I'm also a psychiatrist on the Avery Weisman Psychiatric Consult Service and Acute Psychiatry Service at Mass General Hospital in Boston, and an assistant professor of psychiatry at Harvard Medical School. I'll be speaking about excited delirium. I'm also going to introduce my co-panelists. Scott Beach will be talking about the use of ketamine. He is the program director for the MGH McLean Psychiatry Residency and a psychiatrist on the Psychiatric Consultation and Acute Psychiatry Services at Mass General Hospital. He's also an associate professor of psychiatry at Harvard Medical School. Kim Hartney will be talking about the use of IV Zyprexa. Kim is chair of the Division of CL Psychiatry at Tampa General Hospital. She's also chair of the Department of Psychiatry at Tampa General Hospital and an associate professor of psychiatry at the University of South Florida. Finally, Ann Gross will be talking about liaisoning with emergency medicine. Ann is the Associate Chief Medical Officer at Unity Center for Behavioral Health in Portland, Oregon, and CL Fellowship Director and Associate Professor at Oregon Health and Science University. So like I said, I'll be talking about excited delirium. I have a disclosure in that I am both an employee and management of Edge Health PC, which does business as Author Care. This relationship is not relevant to this presentation. So the question I want to answer with this presentation is, what should a psychiatrist know about excited delirium if they're asked to opine on a patient with excited delirium in their chart, or if their hospital is looking to develop guidelines for caring for patients with excited delirium? And so the objectives of this presentation are to understand what professional groups mean when they use the term excited delirium, understand its similarities to known psychiatric conditions and hypothesized pathophysiology, know what official bodies recommend for its management, and to be able to speak knowledgeably about excited delirium when speaking with our emergency medicine colleagues. To begin, I want to talk about a case, though in this instance, it's a case in the media. A 60-minute segment in December provided a case and context for why this presentation is relevant and important. Elijah McLean was a 23-year-old Black man who was found to be behaving bizarrely by police after 911 was called. He had not committed a crime. Police footage indicates the police were aggressive quickly despite his not presenting as threatening. He continued to walk around and was eventually subdued with a neck hold and handcuffed. Police and medical workers claimed that McLean, who weighed 140 pounds, showed superhuman strength as he continued to struggle against being handcuffed. They interpreted these signs as excited delirium, and when EMS arrived, they administered IM ketamine. The dose they gave was for someone twice his weight, and Elijah McLean died 3 days later after suffering respiratory and cardiac arrest. In this segment, John Dickerson, the 60 Minutes correspondent, interviewed noted forensic psychiatrist Paul Applebaum, who said that, quote, "Excited delirium is a perplexing term. It doesn't correspond to any discrete reality out there in the world. It's a wastebasket phrase. It's a way of explaining what happened without necessarily bearing responsibility for it. If there's a bad outcome, you have a ready excuse at hand. They tend to be young, they tend to be male, they tend to be African American." The term excited delirium has been cited in more than 10% of deaths in police custody. Most recently, it was referred to as a reason for extreme police restraint during Derek Chauvin's trial, where he was found guilty of murdering George Floyd. On a related note, we have noticed an increased propensity in the use of ketamine for agitated patients who consult psychiatrists are often called to assist in managing after the fact. Not infrequently, excited delirium is in the chart as a speculative diagnosis, though by the time we see those patients, they're typically in a different state. So how is the phrase excited delirium currently used in medicine? It remains controversial, inconsistent, and specialty and profession specific. Until recently, it has been described primarily retrospectively in the medical examiner literature, though it has, over time, emerged in emergency medicine. The American College of Emergency Physicians formally recognized excited delirium syndrome as a unique syndrome in 2009. However, other professional organizations, including the American Medical Association, American Psychiatric Association, and World Health Organization, do not recognize excited delirium. In 2019, the APA wrote, quote, Although the American College of Emergency Physicians has explicitly recognized excited delirium as a medical condition, the criteria are unclear, and to date, there have been no rigorous studies validating excited delirium as a medical diagnosis. So what are we talking about when we talk about excited delirium? It seems similar to other disease presentations described in early literature. Luther Bell was a psychiatrist at McLean in the 1800s who first described Bell's mania, or acute exhaustive mania. Bell's mania was characterized by delusions, hallucinations, hyperactivity, frequent fevers, and carried a 75% mortality rate. The description was similar to the psychotic features of schizophrenia, though more extreme, with generalized severe disorganization of behavior, including hyperactive arousal, altered sleep-wake cycle, and elevated core body temperature. Calmiel described a rare and life-threatening psychosis that involved extreme hyperactivity, mounting fear, and stuporous exhaustion. Maudsley in the 1860s also described a violent mania with rapid pulse, constant motion, elevated temperature of the skin, and complete exhaustion. All of these conditions appear to be on a spectrum, if not the same, and notable for derangement of vital signs in addition to other psychiatric signs and symptoms. In 1934, Stodder described a case series of 27 patients where he observed the acute onset of a severe form of psychomotor agitation that he called elementary catatonic excitement. Various degrees of clouding of consciousness and a strong tendency toward violent and self-destructive acts were also present. From the 1950s to the 1970s, the presence in the literature of exhaustive mania subsided with the advent of neuroleptics, but reemerged in the 1980s with the cocaine epidemic. Wheatley and Fishbane described a case series of psychosis and sudden death in cocaine abusers, the first report of drug-related excited delirium. It involved young cocaine-intoxicated males who displayed agitation, motor excitement, superhuman strength, paranoia, mounting fear, hyperthermia, cardiorespiratory collapse, cocaine intoxication, but without any anatomic cause of death. Often, law enforcement was called to the scene, police restrained the individual, and then unexpected sudden death occurred after the use of force using maximal restraint, baton strikes, or pepper sprays. The medical examiner review did not reveal definite anatomic causes of death, although drug overdose, trauma, and underlying cardiac disease were excluded. So we know that the hallmarks of delirium include an acute onset, impaired attention, reduced concentration, diminished awareness of the environment, disorientation, memory impairment, sleep-wake cycle disruption, disorganized thought process, fluctuation in intensity, and so on. If a person dies while delirious, there will be autopsy evidence to demonstrate an underlying medical cause. That is, they did not die due to psychiatric illness. The way forensic pathologists use the term excited delirium implies that excited delirium itself could be a cause of death, or that it renders the patient more susceptible to cardiac arrest when restrained. It's important to remember that potentially lethal acute psychiatric disorders include Bell's mania, malignant catatonia, and NMS, and that severely disturbed behavior that requires restraint may have a medical cause, a primary psychiatric cause, or be caused by recreational drug use. In 2012, the American College of Emergency Physicians reviewed the literature up to that point and concluded that excited delirium syndrome was a syndrome characterized by delirium agitation, acidosis, and hyperadrenergic autonomic dysfunction, usually encountered in subjects with acute on chronic drug abuse or psychotic illness or both. They said, quote, "It is important to emphasize that the term acute behavioral disturbance is definitely not synonymous with excited delirium because delirium, by definition, requires an identifiable organic cause which will be ascertained in autopsy, if not earlier." British and most American psychiatrists do not recognize the term excited delirium because cases of the acute behavioral disturbance which they encounter do not necessarily have an underlying organic cause, which is the defining feature of delirium. Furthermore, the presenting symptoms of acute behavioral disturbance do not necessarily include impaired attention, concentration, memory, and orientation, which are the core clinical features of delirium. The physiology of excited delirium is all speculative at this point. There's a proposal that cocaine-associated excited delirium is a dopamine agonist NMS variant. As we know, NMS is a rare life-threatening idiosyncratic reaction to antipsychotic drugs characterized by fever, altered mental status, muscle rigidity, and autonomic dysfunction. The cocaine-associated syndrome is atypical in having minimal rigidity. Based on these similarities, Costin and Kleber proposed that cocaine-induced excited delirium should be considered a dopamine agonist variant of NMS. Wheatley proposed that NMS might be an attenuated form of acute exhaustive mania or excited delirium, which led him to hypothesize that there may be three related syndromes: acute exhaustive mania, excited delirium due to psychostimulants, and the attenuated variant, NMS. NMS is associated with virtually all antipsychotics. It's also linked to the abrupt cessation of dopamine agonists, including levodopa, pergolide, and amantadine in vulnerable patients. With regard to stimulants, cocaine and methamphetamine increase extracellular dopamine and produce behavioral effects similar to mania. Drug sensitization occurs in addiction and involves increased brain mesolimbic dopamine transport. Repeated treatment with psychostimulants leads to dopamine sensitization in human cocaine abusers. Chronic stimulant abuse leads to an increase in levels of synaptic dopamine. Post-mortem studies show that chronic cocaine abuse leads to compensatory upregulation of dopamine transporter number and function. In contrast, there was no compensatory upregulation of dopamine transporter numbers in a case series of 90 cocaine-related excited delirium deaths. A final common pathway for excited delirium related to chronic stimulant drug abuse, extreme environmental stress, or acute mania of bipolar disorder might be a failure of the dopamine transporter to dynamically regulate synaptic dopamine. This failure of regulation leads to a hyperdopaminergic state, which triggers the violent behavior, delirium, agitation, and motor excitement. Dopamine systems in the brain also play a role in temperature regulation. The rise in core body temperature is most likely induced by dopamine stimulation of D1 receptors in the hypothalamus, which occurs because of a downregulation of D2 mediated hypothermia. A dopamine transporter murine model of hyperdopaminergia displays a distinctive cardiorespiratory and thermal phenotype, providing further support for altered dopamine transporter regulation in excited delirium. Dopamine also regulates sleep and arousal, suggesting that there might be an interrelationship between thermal behavior and circadian rhythms mediated by disrupted CNS dopamine signaling in excited delirium. I'd urge you to look at Mash's paper for an in-depth look at potential physiologic mechanisms for the various symptoms in the syndrome. In 2019, the American College of Emergency Physicians produced a white paper attempting to synthesize the current state of research and found that, despite increased research, the exact pathophysiology of excited delirium remains unidentified. There's no diagnostic test for excited delirium. A proportion of patients with excited delirium progress to cardiac arrest and death. It's impossible at the present to know how many patients receive a therapeutic intervention that stops the terminal progression of the syndrome. The paper draws lineage from Bell's mania, which is thought to be similar or the same. And they note that a typical course involves acute drug intoxication, often a history of mental illness, struggle with law enforcement, physical or noxious chemical control measures, or electrical control device application, the sudden and unexpected death, and an autopsy which fails to reveal a definite cause of death from trauma or natural disease. The incidence of death is thought to be 8.3% and associated with stimulant use, including cocaine, meth, and PCP. Over 95% of published fatal cases are males, and the average age is 36. They're often found to be hyperaggressive with bizarre behavior, found to be impervious to pain, combative, hyperthermic, and tachycardic. Among those with psychiatric illness, which is the second highest cohort of excited delirium patients who die, literature frequently cites the abrupt cessation of a wide variety of psychiatric medications, though most frequently antipsychotics. A review of excited delirium published in academic emergency medicine in 2018 proposed the following behaviors and signs as reflecting a potential diagnosis of excited delirium, though without guidance regarding how many and whether any are more specific to the syndrome than others, which reflects the nascent quality of the research in this area. Behaviors could include severe agitation, violence, thrashing, bizarre behavior, paranoia, hypervigilance, a lack of tiring and constant physical activity, unusual or unexpected strength, increased pain tolerance, police noncompliance and combativeness, attraction to reflective surfaces such as mirrors and glass, stupor, fear, and panic. Clinical signs include tactile hyperthermia, being inappropriately clothed despite the weather, tachycardia, tachypnea, sweating, seizure, and mydriasis. Recommendations for management of this condition largely come from case reports and speculation. There have not been any prospective studies of treatment of excited delirium syndrome. There are some case reports in literature. This particular set is worth looking at because the diagnoses seem likely to be excited delirium as written about in the literature I've gone over already. The first case involves a 35-year-old male who was white and weighed 103 kilograms. He was displaying bizarre behavior, including being shirtless in 11-degree Fahrenheit weather. He was agitated and incoherent. He was given 500 milligrams of IM ketamine through his clothing. His pre-hospital vital signs were a heart rate of 122 and respiratory rate of 32. In the ED, he was found sedate and unresponsive with a temperature of 102.4 and elevated vitals. His arterial pH was 7, his PCO2 54, bicarb 13, creatinine 1.9, and CK over 2500. Urine tox showed cocaine metabolites, but not acute intoxication. He was intubated due to acidosis concerns. His CK peaked at 3400, and he was extubated 72 hours later when his mental status returned. He did not remember being violent and did not recall the restraint occurring. A second case involved a 40-year-old man who was Black and weighed 80 kilograms. He had a history of schizophrenia, chronic cocaine and alcohol use, and Hep B. He was uncooperative, agitated, partially nude, and it was 17 degrees outside. After a brief chase, he was followed and then tasered and tackled. EMS gave him 375 milligrams of IM ketamine. He was sedated within 3 minutes. His pre-hospital vital signs were a heart rate of 123 and a respiratory rate of 42. In the ED, he was sedate and unresponsive. His temperature was 101.3. His heart rate was 168. His other vital signs were elevated, and his arterial pH was 6.7 with a PCO2 of 44 and bicarb of 5. His urine tox was also positive for cocaine, but not acute use. He was intubated and then extubated after 48 hours. He admitted to chronic cocaine use, but none within the prior week. The most recent recommendations provided for management come from a review article from earlier this year by Kim and others, where they attempt to synthesize case data into a set of recommendations for excited delirium. Their first-line recommendation is antipsychotics or benzos, either alone or together. Droperidol 5 to 10 milligrams IM and midazolam 5 to 10 milligrams IM have the fastest onset of sedation and may end up being better than lorazepam. They're the first-line recommendation. Ketamine is more frequently associated with airway compromise requiring intubation. A lower dose of ketamine, such as 2 milligrams per kilogram, may be adequate without airway compromise, though doses as high as 5 milligrams per kilogram of IM ketamine have been shown in case reports, often with complications. Haloperidol is also an option with adequate sedation, often achieved within 25 to 30 minutes. Peak effect is observed at 90 minutes. In patients who were given 5 milligrams of IM haloperidol, 18% of those patients required additional sedation within an hour of the initial dose, compared to 11% for droperidol or olanzapine. There's no formal consensus on recommended dosages for ketamine for excited delirium syndrome. Clinicians at the University of Maryland performed a retrospective review looking at adherence to guidelines created internally, which were: if the patient had IV access, IV lorazepam 2 milligrams and haloperidol 5 milligrams or olanzapine 10 milligrams were given. Then second line, ketamine 2 milligrams per kilogram, or if the patient did not have IV access, IM lorazepam 2 milligrams and haloperidol 5 milligrams, then IM ketamine 1 milligram per kilogram. This study had a small N of 31 patients. They found that only 8 of 31, or 26%, were treated according to guidelines. In this real-world situation, 29 of 31 received ketamine for excited delirium, and 9 of those patients received multiple doses. Ketamine led to statistically significant decreases in systolic BP, heart rate, and RASS score. 6 of 29 required intubation for either inability to protect airway, excessive oral secretions, or the need to facilitate a timely medical evaluation. They also found that the mean dose of ketamine for patients who were intubated was 3 milligrams per kilogram IV and 4 milligrams per kilogram IM versus a mean of 2.5 milligrams per kilogram IV and 3.5 milligrams per kilogram IM for those not intubated. In my last slide, I want to highlight a few elements worth remembering for psychiatrists who are asked to manage or develop guidelines for excited delirium. The speculative pathophysiology is complex and likely involves elements of other syndromes with which CL psychiatrists are familiar. In many instances, it is likely a sequelae of chronic stimulant use, but may not be the result of acute stimulant intoxication. Its progenitors and analogs are likely to be catatonia spectrum syndromes such as delirious mania and NMS. It is most likely to present as not just difficult to control agitation, but bizarre behavior oblivious to extreme external conditions such as police presence or dangerous temperatures, as well as deranged vital signs, acidosis, and a high risk of death due to arrhythmia. The veracity of excited delirium as a distinct syndrome is in question. It is likely a distinct process, though more precise verbiage that accurately places it in a medical context would decrease the likelihood that it is declared a condition by lay people and therefore mismanaged. It is also worth considering how spreading the phrase excited delirium from a medical context may produce racially discriminatory application and outcomes with retrospective blamelessness assumed. Professional societies have not yet settled on whether excited delirium is a distinct entity, nor what symptoms might comprise it. Management should begin with antipsychotics and benzos before ketamine is considered. Scott will cover the ins and outs of using ketamine on the CL service. Though we do not condone treating a syndrome whose existence is in question, as treatment should only flow from an accurate diagnosis, we must be conversant with what exists in the literature on excited delirium, both to reasonably guide our EM colleagues and to advocate for safe management of our patients. And with that, I will hand it to Scott to talk about ketamine.
Okay, thanks, John. So I'm going to talk today about the use of ketamine for agitation. And I have one disclosure, which is that I receive honorarium for the Psychopharmacology Institute, and I've given similar talks for them, though not specifically about ketamine. So I'm going to start with a case, and this talk is really a little bit about my journey as it pertains to ketamine, from one of intense frustration to one of extreme skepticism, maybe to one of mild skepticism at the end, and hopefully not hitting learned helplessness at any point along the way. So this is a real case that we had in the emergency room, 27-year-old female with a history of multiple substance use disorders who presented requesting dual diagnosis. Her urine tox was positive for amphetamines, and she admitted to using crystal meth prior to the presentation. About 2 hours after the initial evaluation by psychiatry, she developed symptoms of psychosis, including paranoia and agitation. Psychiatry recommended olanzapine 2.5 milligrams. Over the next 4 hours, which happened to be overnight, unbeknownst to psychiatry, the patient remained agitated and received 20 milligrams of IM haloperidol, 15 additional milligrams of olanzapine, 5 milligrams of lorazepam, and 25 milligrams of diphenhydramine. On reassessment by our team in the morning, she is diaphoretic, writhing in bed, and speaking nonsensically. Despite our recommendations, which were to start with propranolol because she seemed to be akathenic, ketamine was administered, and shortly afterwards, the patient required intubation and was admitted to the ICU. And I would say this is a fairly typical case in which I encounter ketamine in the ED setting. And so one of the first things that I wanted to do in setting out to put this talk together is figure out what are the emergency medicine docs actually seeing in the literature as it pertains to ketamine? And I think this is a really useful exercise when we're faced with a controversial issue, particularly one that crosses disciplines. I think it's really important for us to be familiar with the literature that our colleagues are seeing. And if you look in the emergency medicine literature, just over the past year, ketamine is everywhere. These articles are all from 2021, and they're only a sampling of the articles that pertain to ketamine use. So ER docs are being constantly reminded of the presence and the benefits of ketamine, specifically for the use of agitation. To back up a little bit, ketamine was introduced as a general anesthetic in the late 1960s. And on the right-hand side there, you can see the very first article describing that novel drug. Though it was initially well received, it fell out of favor actually very quickly because of what came to be known as an emergence reaction. And that was the idea that as patients awoken from their ketamine state, they tended to have hallucinations. So pretty quickly, it actually wasn't used very much in hospital settings. Despite that, it ended up being the most widely used battlefield anesthetic in the Vietnam War. Ketamine is a derivative of phencyclidine, or PCP. It's a non-competitive NMDA receptor antagonist, but it only binds with about 10% of the potency of PCP. And as we'll talk about, it has some excitatory effects. It's thought that ketamine produces its effects by dissociating the limbic and the thalamoneocortical systems. So the user is awake but unaware of all sensory input and amnestic. We also know ketamine is a novel antidepressant, but on the consult service, I think we really see it in three primary contexts. We occasionally see it as analgesia for dressing changes in burn patients. That was actually the first way that I encountered ketamine as a CL fellow. We see it nowadays somewhat as a sedative agent for intubated patients, and that would be a whole separate talk. But what we're going to focus on today is its use in the emergency room and occasionally on the floors for acute agitation. The dosing for all of these indications is weight-based. It's typically 1 to 2 milligrams per kilogram IV or 2 to 5 milligrams per kg IM. It's important to keep in mind that the IV to IM ratio is about 2 to 1. And it's metabolized hepatically with a pretty short half-life of 2 to 3 hours. Interestingly and importantly, higher doses of ketamine do not appear to deepen sedation after the initial dissociation. We also know ketamine as a drug of abuse, and some of the ways that manifests and some of the effects of ketamine as a drug of abuse can be illustrative for us. Its history of recreational use dates back to at least 1970. Use tends to be regional. I was interested to find that the largest pockets of use currently are in East and Southeast Asia. The typical recreational dose is 100 to 200 milligrams, and it can be used in a variety of ways, though the intoxication tends to be relatively brief regardless of how it's used. Classically, the intoxication with ketamine is described as involving depersonalization, so out-of-body experiences, sensations of floating, often vivid dreams, and sometimes hallucinations. It can have negative connotations as well, and that's described as falling into a K-hole. When intoxicated patients present to the ER, their most frequent complaints are chest pain, palpitations, and anxiety, and the most frequent severe complications of ketamine use are agitation and rhabdo. Patients over time can develop psychological dependence and tolerance, and chronic use has been associated with the development of psychosis, and we'll come back to that. As I was preparing this talk, I wanted to sort of comb through the literature, and I'm not going to be exhaustive, but it is interesting to see the various ways in which ketamine has been used over the decades, starting in the 80s, being used primarily for procedural sedation for children. In early 2000, palliative care literature started occasionally mentioning ketamine. In 2010, shifted to using procedural sedation for adults, and then it wasn't until pretty recently that we started seeing it for continuous sedation of ventilated patients. And similar trends can be seen in the use in agitation. As recently as 1997, the literature declared that ketamine was relatively contraindicated for agitated or critically ill patients, that it should always be given with a benzodiazepine, and that it should be avoided in patients with TBI. That started to change about a decade later when there started to emerge reports of the use of ketamine for agitation, initially in military settings and then very quickly in pre-hospital settings administered by EMTs. And then later on, it started being used in the emergency room. But that was really recently, only 2015. And then you can see that things have progressed pretty rapidly since then. So a question that we should always ask ourselves when there's a new drug on the block that our colleagues seem to really like is, what exactly do they love about this medication? So what do ER docs love about ketamine? Well, there's a lot of advantages. It has a really rapid onset, often described as happening in 1 to 3 minutes. As I mentioned, it has both IV and IM delivery, and emergency medicine docs really love having an IM option. It induces a profound dissociative state, so patients tend to be calm. It has minimal cardiorespiratory depression, and that's really novel among medications that we use to sedate patients. In fact, ketamine not only doesn't cause cardiorespiratory depression, but it has some sympathomimetic effects. It's also useful for acute pain, so it can be used as analgesia in addition to sedation. And it has a pretty good success rate. About 85% of patients achieve some degree of sedation. So lots of reasons for emergency medicine docs to really like ketamine. There are some downsides, though, from a medical standpoint. Given its sympathomimetic effects, it can increase blood pressure, heart rate, and cardiac output, and that's not great in some patients. As John alluded to, probably the biggest downside from a medical standpoint is the need for intubation. Up to 63% of patients in some studies who receive ketamine end up intubated. Systematic reviews put the number at more like 20 to 30%, but that's still a huge percentage of patients who get ketamine who go on to require intubation, way higher than other sedative agents. This may occur due to increased secretions. Ketamine can also induce nausea, vomiting, and laryngospasm. I mentioned that ketamine at one point was contraindicated in TBI because it was thought to increase intracranial pressure. Nowadays, it's thought to actually probably decrease intracranial pressure or have neutral effects. So that's not as much as a concern. But death has been reported, as John alluded to, in cases of ketamine used for agitation. So there are some reasons to be concerned about it from a medical standpoint. The next thing I asked myself is, why are we so scared of ketamine? Why are we as psychiatrists scared of the use of ketamine for agitation? And I think, again, there are a number of reasons for that. In terms of acute neuropsychiatric effects, it can cause paranoia, hallucinations, increased agitation, maybe even catatonia. And chronically, it can cause neurocognitive deficits. In animal models, it's been shown to be directly neurotoxic and to cause bilateral frontal and left temporoparietal white matter degeneration. And in a retrospective review of 50 patients receiving continuous ketamine for pain or sedation, 22% of them had psychiatric side effects, so a not insignificant number. But probably the biggest reason why psychiatrists worry about ketamine has to do with the relationship between ketamine and schizophrenia. And I want to spend a little bit of time talking about this because I think it's important for all of us to be familiar with this literature. We know that PCP is a really good model for schizophrenia. And so the initial thought was that ketamine might also be a good model for schizophrenia. And that turns out to be somewhat true. In healthy volunteers, ketamine does induce symptoms that are similar to schizophrenia, things like thought disordered thinking, perceptual abnormalities, blunted affect, and emotional withdrawal, but not exactly identical. So healthy volunteers who use ketamine don't tend to experience auditory hallucinations or paranoia. They do tend to experience temporal and spatial distortions that are not typically seen in schizophrenia. So it's not exactly the same. However, there is a phenomenon resembling even the negative symptoms of schizophrenia that occurs in healthy volunteers that's stronger with ketamine than with other hallucinogens like DMT. And that includes catatonia-like features, which have been described in healthy volunteers in the setting of ketamine use. So what about the idea of using ketamine in patients with schizophrenia? That's one of the few indications where emergency medicine docs will actually pause. And in a lot of algorithms, ketamine is relatively contraindicated in patients with schizophrenia. So where does that come from? Where there have been 3 studies over the years. The first occurred in 1995. That was an open label study including only 9 patients, all of whom had schizophrenia. Initially, they were on Haldol for at least 4 weeks before they were administered ketamine, but then the ketamine administration was repeated following a haloperidol washout. And in those patients, their psychosis increased at 20 minutes for both the 0.3 mg per kg and the 0.5 mg per kg doses. They had a short-lived increase in their psychosis, returning to baseline by 90 minutes, but about half of them reported a spontaneous recurrence of symptoms within 24 hours, almost like a flashback phenomenon. And what was particularly notable is that in addition to the symptoms seen in healthy volunteers who took ketamine, auditory hallucinations and paranoia were present in many of these patients with schizophrenia during their ketamine intoxication. A few years later, there was a second, better designed study. It was a double-blind, placebo-controlled study. 13 patients with schizophrenia who had been neuroleptic free for 2 weeks were administered ketamine. And again, patients experienced a brief exacerbation of both positive and negative symptoms. Compared to healthy volunteers in that study, the deficits were greater, meaning there was more psychosis in patients with schizophrenia. And patients with schizophrenia, again, experienced auditory hallucinations and paranoia, whereas healthy controls did not. In the third study, which was done by the same group as the first study, that was also double-blind and placebo-controlled. There were 18 healthy volunteers and 17 volunteers with schizophrenia. The patients with schizophrenia were on a fixed dose of haloperidol prior to ketamine administration. Both groups experienced an increase in psychosis, and the magnitude of changes was similar. But again, the psychotic symptoms in patients with schizophrenia were at the upper end of the spectrum, including hallucinations and delusions. And that last point is really important because this study is often cited in emergency medicine literature as sort of counterbalancing the concern about using ketamine in schizophrenia. And what's said is patients with schizophrenia had no different reactions than healthy volunteers. And again, that's not actually true if you look at the specifics of the types of symptoms that they experienced. So getting to that point, how do emergency medicine physicians counter these concerns about psychosis as a possible outcome of ketamine administration? Well, they take a few different approaches. One thing that's really interesting is they argue that psychosis is different from schizophrenia. So many algorithms say that ketamine is relatively contraindicated in patients with schizophrenia, but there's no contraindication for giving it to patients with other psychotic spectrum disorders, like bipolar disorder with with psychosis, major depression with psychosis, a brief psychotic disorder, a substance-induced psychosis, or a psychosis secondary to a general medical condition. And in actuality, there's really no evidence to suggest that those forms of psychosis would have a different reaction to ketamine than would patients with schizophrenia. Interestingly, there's some literature that also contends that the lower doses that were used in those studies from the late 90s are actually more likely to cause psychosis, and that by giving higher doses of ketamine, they may be less likely to cause psychosis. As far as I could find, there's nothing in the literature that actually supports that, but that is a claim that sometimes is made. It's also a common argument to highlight the side effects of more traditional agents. So to point out that nothing's perfect. And yes, ketamine has these neuropsychiatric effects, but all the other agents that we might use for sedation or agitation control have their own side effects. And then there's also some emerging reports of purported established safety. So giving patients with psychiatric illness or with schizophrenia ketamine, and then reporting that there are no worse outcomes than patients who receive benzodiazepines. It's important to keep in mind that the numbers in these studies are extremely small and too small to really draw meaningful conclusions. Another trend that is really important for us as consult psychiatrists to be aware of in the literature is the comparisons of ketamine and haloperidol. So this has been really well reported and well studied in the last 2 or 3 years. There are a number of studies, and many of them look pretty good for ketamine. In most of the studies, the mean time to sedation or the mean time to a patient being no longer agitated is much faster for ketamine than haloperidol. That's great. It's great to have medications that act really quickly. But it's also important to keep in mind that not everything is great in terms of these studies. So in one of those studies, for example, 49% of the patients receiving ketamine had complications as compared to 5% who received Haldol, and 39% of the patients receiving ketamine got intubated as compared to 4% who received Haldol. In another one of those studies, 33% of the ketamine group required psychiatric hospitalization as compared to 5 to 10% for the other groups who got haloperidol or a benzodiazepine. That difference was actually not commented on anywhere in the study. And then finally, there's a retrospective review again showing that ketamine has higher intubation rates and actually more additional chemical restraints needed. And that's commonly observed in the literature as well, that ketamine helps calm people down for a brief period of time, but most of those patients are going to need additional agents after that. So there is good and there is bad. And where we end up is, I think it's important for all of us to recognize that ketamine is not going away. It is widely used, widely reported in the EM literature, and widely embraced. And so the use of ketamine is only likely to increase. So we can't continue to just bury our heads in the sand and hope it goes away and sort of say, okay, we're not going to be involved with those patients who get ketamine, because we're going to have to be involved in managing them. It's also really important for us as we collaborate with our emergency medicine colleagues to recognize that they're not using ketamine necessarily in a reckless way. From the perspective of emergency medicine physicians, ketamine has a lot of advantages. It has advantages to patient safety in reducing agitation and to staff safety. And those are really important things from the standpoint of emergency medicine. There's no agent that's going to be a magic bullet for all agitated patients. And so I think what we want to do is try to work really collaboratively with our emergency medicine colleagues and let them know what our concerns are about using ketamine in specific patients, particularly those who present with prominent psychosis. Educate them on the effects of ketamine, the downsides of ketamine, and why we worry about it. And most importantly, remain closely involved when ketamine is used. In that case that I highlighted to begin, and in many other cases, my initial reaction is to just walk away and say, fine, you manage it. And it can be hard to resist that. But those are exactly the situations in which we want to remain involved, because we need to be there to help monitor for neuropsychiatric effects and to help advocate for our most vulnerable patients. So I would encourage all of you to really familiarize yourself with the ketamine olanzapine literature, and to recognize that this is going to be an ongoing dialogue between emergency medicine and psychiatry, and we can play a huge role in helping to educate and mitigate bad outcomes. I'm going to now hand it over to Dr. Hartney, who's going to talk about another emerging trend in agitation management, and that is the use of intravenous olanzapine. Kim?
I'm Kim Hartney. I'm a practicing CL psychiatrist and chief of the division CL psychiatry at the University of South Florida Morsani College of Medicine. And I will be discussing intravenous olanzapine. There's a brevity of intravenous antipsychotic options, which is prompting out-of-the-box considerations in offering intramuscular approved medications in off-label intravenous routes. This is the case with the increasing introduction of intravenous olanzapine. Additionally, even though psychiatrists serve as the experts in neuromodulation, we are seeing that our ER colleagues are significantly more prolific writers on the subject and the use of intravenous olanzapine. As it pertains to disclosures, I have nothing to disclose for this presentation. I would like to begin our experience with IV olanzapine use with a brief review of olanzapine itself. Olanzapine is an atypical antipsychotic with mechanisms of action that include central blockade of dopamine D2 receptors, central blockade of muscarinic receptors, central blockade of serotonergic, 5-HT2 receptors, and peripheral blockade of alpha-1 receptors. It is approved by the FDA for oral and intramuscular use in the treatment of adults and adolescents with schizophrenia and bipolar I manic and mixed episodes. Olanzapine also offers expanded off-label use, including for adjunctive treatment in depression with psychosis, acute agitation management, nausea, vomiting, and headaches. The central structure that you see here in the page is actually olanzapine, and you'll also know that it's the most structurally similar to clozapine, our most effective antipsychotic, although not necessarily for agitation. So in reviewing the manufacturer's insert regarding use of olanzapine for agitation, and there's nothing in there for the use of agitation, and certainly not in an IV route. So where is this coming from? Consistent with the title of our session, by and large, the use of IV olanzapine is emerging from the ED setting. When a psychiatrist starts the selection process for an antipsychotic for daily therapeutic effects, we start carefully weighing D2 receptor blocking potency with cholinergic, alpha adrenergic, histaminergic, and serotonergic burdens. The nuances of selecting an antipsychotic for daily therapy, as well as acute agitation, are ingrained in psychiatric residency, but is not included in the didactics of other disciplines. In the emergency department, when faced with the emergent need for control of the symptoms of agitation, antipsychotics, benzodiazepines, or both are the mainstay of therapy. Our ED colleagues' research overwhelmingly have one objective, and that is time to sedation. Our ED colleagues' selection process for an antipsychotic for emergent control of agitation focuses on what is feasible to get into the patient, as in what route of administration is available, and time to achieve that sedation. I would even suggest that psychiatrists may be more like Alan here from The Hangover. He's charismatic, eccentric, musing, and underestimated. But when the nuances of antipsychotics are needed, we are the experts in neuromodulation. Our emergency room teammates are sort of like Ace Ventura, going fast and furious with the ideas, maybe not that clear on the mechanisms, but getting the job done. So naturally, the first step in the antipsychotic selection process would involve around getting the medicine into the patient. All FDA-approved antipsychotics have approval for oral routes. In acute settings, though, parenteral routes are king in that they typically act more rapidly than enteral, and particularly intramuscular and intravenous routes, as they offer essentially 100% bioavailability. Antipsychotics with FDA approval for intramuscular routes that are not long-acting injectables include the atypicals, aripiprazole, olanzapine, and ziprasidone, and the typicals of chlorrazepine, fluphenazine, and haloperidol. I'd also have you note that both olanzapine and ziprasidone, They made submissions to the new drug application, and they both noted an indication of agitation rather than schizophrenia to broaden their market. A clear disadvantage of intramuscular to intravenous is the pain and discomfort that comes at the site, an increased risk of muscle breakdown, elevations in CPK, and risk of rhabdomyolysis. And yet, there's not a single antipsychotic with FDA approval for intravenous use. I clinically prescribe more IV haloperidol than vitamin B12, but it's not FDA approved. Initially, everybody will start following a manufacturer's recommendations to the letter. Then with time, we have what's called medical practice. It takes over. The manufacturers have no incentive to take on the risk of these extended indications. And in the end, chlorpromazine, droperidol, and haloperidol have IV formulations for off-label use. I now present the case in March 2021 of a 41-year-old female psychiatrist who's running a consultation service and assessing a patient for the management of agitation and delirium. The patient's in 4-point restraints, is agitated and distressed. The patient has an IV and normal EKGs. The psychiatrist isn't going to reach for a benzodiazepine because of the delirium. And the patient is already on a maximum dose of an alpha-2 agonist. The psychiatrist is then told that her quaint 1,100-bed level 1 trauma hospital is suffering the effects of a national shortage of IV haloperidol and IV chlorpromazine. That scenario above is what prompted my search for an IM antipsychotic that could be introduced IV. I recognize that there are risks of changing routes of administration. We know that identical drugs can produce different results depending on the route of administration. For example, when naloxone or Narcan is used IM, it antagonizes the CNS opioid receptors, acting as the treatment for opioid overdose. However, when we use it PO, it can exclusively work on the GI tract and minimize constipation, but not affect the opioids. This tendency to have different reactions to different routes is less often the case in exchanging parental routes IM to IV. So we first looked to our formulary when I was to see which antipsychotics in IM preparation were readily available. I tended to search for an atypical for potentially less EPS, although we know that many typicals when in IV formulation offer less EPS. And I was looking for an atypical because it tended to have increased availability in our hospital's formulary. At my institution, my options were ziprasidone and olanzapine. Now, we wanted to use the new IV for acute agitation. So we wanted to compare the success rates of olanzapine IM with other IM antipsychotics. IM olanzapine was statistically superior to placebo and comparable to IM haloperidol and lorazepam at reducing the positive and negative symptom scales and excited component of the PA and SSS. Also, we know that intramuscular olanzapine was superior to intramuscular haloperidol and lorazepam in 3 studies when you excluded dementia as the cause for agitation. There is a noted risk of intramuscular olanzapine and associated bradycardia, which in one study occurred in 64 of 850 patients. 40 of the 64 actually had a reduction in resting blood pressure or orthostatic drop. The autonomic changes that are seen in intramuscular olanzapine are felt to be the result of alpha-1 adrenergic blockade, and it tends to occur more in non-agitated patients than agitated patients. So I could see the benefits and the risk of IM olanzapine. So then I set out to compare it to IM ziprasidone, which was also available. But IM ziprasidone shares the same QTC prolongations as PO ziprasidone, with 10 milliseconds greater than alternatives like Risperdal, olanzapine, and quetiapine and haloperidol. The risk of QTC prolongation suggested to me a theoretically lower ceiling for dose titration of the ziprasidone IM. And so therefore, I decided to go with olanzapine. The recognized benefit of IV over IM routes of administration tends to fall in medication's reliability and absorption and rapid effects. With delayed effects of the IM route, there tends to be more redosing rates, and then as a result, there's resulting over-sedation is more common. So I was processing there that might further support my use of IV. I additionally looked at the contents of what's in olanzapine IM ampules. The ampules include olanzapine, they include water, it includes lactose monohydrate, which is a simple glucose, and tartaric acid, which is regularly used in other IV medications like metoprolol. So the IM ampule contents should be safe for IV administration. Our team then underwent a literature review with no mention of olanzapine prior to 2007. And that was limited to a case series that was done in an ER in Australia. I can't speak to how the intravenous olanzapine was selected in the study, but the study of 14 patients showed no adverse events, and dosing ranges from 2.5 milligrams to 15 when olanzapine was given IV alone, in combination with midazolam or in combination with droperidol. In 2012, Chan's research group completed the most robust study to date, and it came in the form of a randomized double-blind placebo-controlled prospective study by ER physicians in Australia, again, with a focus on time to sedation, also looking at lowering risk of resedation and lowering benzodiazepine requirements. Chan, the researcher, referenced a survey that showed that midazolam there was their choice sedative, and therefore the study looked at using droperidol IV or olanzapine IV only in adjunct to midazolam. The study found that IV olanzapine arm had the most rapid sedation at just 5 minutes, although notably both the droperidol and olanzapines as adjunctive measures sped the rate of sedation, and that had a confidence interval of 1.23 to 2.11. Chan's research group further noted that the antipsychotic adjunct to midazolam arms both offered comparable to less airway obstruction, less oxygen desaturation, less hypotension, and less lowering of the GCS. Secondary analysis showed that patients experienced less desaturations with the IV olanzapine combination when compared to the IV droperidol combination. So that's especially notable given that the Electronic Medicines Compendium has a current warning regarding the combination of IM olanzapine with benzodiazepines leading to increased respiratory depression. This study did not find that to be true when it was observed with IV olanzapine. The groups, all of the arms, the groups had no difference in emergency room length of stay, and the QTC for all of the arms of the study were equivalent at the 1 hour mark. There were study weaknesses. Perhaps it was underpowered. We would certainly have preferred if the EKG would have been done before the medication was administered and repeated an hour after. There was no account for benzodiazepine tolerance that might have affected the midazolam control group. The sedation scale is open to observer bias, and the data suggests that perhaps the control arm of midazolam group actually received the dose later. So perhaps there isn't quite as much of a delay with the control group of midazolam. So then we start reviewing the evidence. In 2013, droperidol, which is a favorite in ER settings, was given a black box warning, which resulted in less use of the droperidol. As a result of the less use, there was less raw materials produced, and resulting shortage of raw materials for droperidol resulted in regional increases in the use of IV olanzapine. So right then, if you start looking and following 2013, the evidence for trialing IV olanzapine increased considerably in the literature. First was a very large 713 cohort study that looked at IV olanzapine for a variety of uses in the ED. The most common use of IV olanzapine was used for agitation, as this hospital had a droperidol shortage. The study supported the use of IV olanzapine in the management of acute undifferentiated agitation. There were a few complications. 2 of the patients demonstrated akathisia that resolved. 14% of patients who received the IV olanzapine, so 14%, had some form of respiratory complication, with 2.1% of those deemed serious. And of that 2.1%, 7 patients were intubated, but only 3 of those were felt to be, quote, possibly related to the olanzapine. The authors of that study actually noted that this rate of respiratory complication was not different than that of other sedatives in the management of agitation. The Martel group also noted that for 66.8% of patients, a single dose of olanzapine, the doses varied from 1.25 milligrams to 10 milligrams, achieved adequate sedation. Next, a 2017 prospective study with an aim of observing safety and efficacy of olanzapine and IM in the ED for a variety of indications occurred. Note that this was actually the first study where the outcomes assessed were for safety rather than time to sedation. So both the IV and IM olanzapine formations offered a low risk for respiratory depression, but that risk was 3.7% in the IV group compared to the 2.0% in the IM group. Fewer of the IV olanzapine recipients needed redosing sedation compared to the IM group. And the study concluded that both IM and IV olanzapine were safe. At the same time, a 2017 randomized controlled double-blind trial compared efficacy of sedation amongst midazolam and droperidol combination, droperidol monotherapy, or olanzapine monotherapy, all in IV form. Surprise, surprise, the results showed that the combination of a benzodiazepine with an antipsychotic were more sedating than either of the IV antipsychotic monotherapies. But in review specifically of the IV olanzapine, there was no difference in respiratory depression. There was actually modestly more respiratory depression in the combination groups. There was no difference in QTC at 30 minutes post-administration, although it was noted that 50% of patients had no pre-admission EKG due to their agitation status. In that study, the doses that they used was midazolam 5 in combo with droperidol 5, and then the monotherapies each used 10 of droperidol and 10 of olanzapine. So it makes sense that with that same study, when they did a subgroup assessment, looking if the agitation was solely because of methamphetamine-induced agitation, the results were the same. That still the combination of a benzodiazepine with an antipsychotic resulted in more sedation, but it did result in more increased respiratory depression. In 2018 and 2020, there were two separate case reports that moved the use of IV olanzapine outside of the ER and into patients with complex medical illness. In one patient, IV olanzapine was safely given to a patient who had a QTC of 490, impaired renal function, and a risk of bleeding with intramuscular injections. In the next patient, IV olanzapine was safely given to a geriatric patient. The patient had suffered an MCA. He had platelets of only 9,000 and a QTC that had an increased baseline from 447 to 485 after he received some Haldol, ondansetron, and ziprasidone. So this patient was very sick. They changed the patient to olanzapine IV, and the agitation management was felt to be much improved. Over a 3-day period, he received 62.5 milligrams of the IV olanzapine. His EKG and QTC, which had previously gone up, had no further changes. The patient was noted to have a decrease in blood pressure, though, after every single administration of the olanzapine. No intervention was required, and also they didn't separate out that at the same time morphine, dexmedetomidine, and diazepam were also being given. Finally, in 2020, there was a large retrospective analysis of 252 with a total 252 patients, and they were able to signal out individual administrations of IV olanzapine. And there were 1,247 single administrations that they looked at. When they looked at these single administrations, they noted that hypotension occurred in 5.2% of the administrations. However, there was no intervention was required in 74% of those, and almost every adverse event occurred in the presence of concomitant medications that have the same blood pressure effects. So what are our conclusions here? We need more clinical trials. We need prospective comparatives are needed. There are no current prescribing guidelines available for IV olanzapine. There are no pharmacokinetic investigations into the distribution, metabolism, and elimination with this route. IV olanzapine is increasingly recognized, though, as effective and safe for sedation in the ED, but is controversial due to perceptions that evidence is thin. IV olanzapine 5 and 10 milligram produces similar rates of sedation with 10 minutes compared to with droperidol IV. Thus far, there's no evidence of torsades with IV olanzapine, and intravenous olanzapine offers more rapid sedation, 6 minutes, compared to intramuscular at 15 to 45. I'm anticipating that going forward, I think we're going to see more and more use of IV olanzapine, particularly as our hospital has continued to have shortages with access to IV haloperidol, IV thorazine, and ours doesn't even have IV droperidol on formulary. It does seem overarchingly that ERs tended to like to use IV droperidol. So as that shortage was national, I'm anticipating that IV olanzapine is going to be much more common in our future.
Hi, my name is Dr. Ann Gross, and I am the Associate Chief Medical Officer at Unity Center for Behavioral Health and the Consultation-Liaison Fellowship Director at Oregon Health and Science University. Up until recently, I was serving in the role of the Medical Director of our Psychiatric Emergency Service at Unity, and it was in this role that I was asked to discuss the topic of navigating challenges at the interface of emergency medicine and psychiatry. I have no relevant disclosures in reference to today's talk. So while Drs. Hartney, Beach, and Taylor spent time talking about perhaps controversial differential diagnoses and treatment strategies that occur in the setting of the emergency department, that will not be the focus of my talk today. Instead, I hope to set a framework for why this conversation is perhaps more important than in many recent years in the setting of the pandemic. In June 2020, the CDC Weekly Morbidity and Mortality Report queried over 5,000 individuals to better understand the role of the pandemic on individuals' mental health symptoms and substance use. Concerningly, although perhaps not surprisingly, over 40% of individuals reported worsening mental health symptoms and/or use of substances. Over 30% of individuals reported worsening depression and anxiety. 26% reported trauma and stressor-related disorders. 13% reported starting and/or using more substances or alcohol. And a very concerning 11% of respondents reported seriously considering suicide in the last month. This was 2 times pre-pandemic rates of mental health in our community. Multiple stressors associated with the pandemic, of course, have led to worsening mental health and substance use conditions, insecurity of multiple types, health insecurity, financial insecurity, occupational insecurity, housing insecurity, and of course, this social isolation that has been kind of therapeutic, if you will, to try to prevent the coronavirus spread certainly caused a lot of stress and emotional disconnect for our community. The stressors, of course, also have been found to disproportionately affect communities of color and minority populations. So in addition to increased rates of mental health conditions and substance use in our community, other questions have come about to better understand what the role is of pre-existing mental health conditions on outcomes if one does become ill with coronavirus. Wang and colleagues asked this question and found that individuals with diagnoses of mental health conditions within the last year, specifically depression and schizophrenia, had increased risk of developing coronavirus. In addition, they found that individuals with comorbid mental health conditions and coronavirus had increased rates of mortality. Namani and colleagues also studied the overlap between coronavirus and outcomes of mortality in individuals with mental health conditions and found that individuals with schizophrenia spectrum disorders are almost 3 times more likely to die from coronavirus, and this was a risk factor second only to age in their study. So one might ask, if you're increasingly seeing mental health conditions in our community, if we're worried about the overlap of mental health conditions and coronavirus and mortality in our patients, where are people going to seek care? Holland and colleagues asked this question in JAMA Psychiatry in February 2021, asking, are there increased rates of presentations of mental health conditions and substance use disorders in our emergency department settings? Their study was large, over 190 million emergency room visits, and they found that yes, in the emergency department, there have been increased risk or increased rates of mental health condition presentations, suicide attempts, overdoses, including opiate overdoses, intimate partner violence, and childhood abuse and neglect. So I'm hoping to set the framework for, again, why this conversation is so important in the setting of the pandemic. In order to better understand the challenges that our emergency department colleagues are facing as more patients are coming and seeking treatment for their behavioral health conditions, I asked the question to them, what are the major challenges from your perspective in caring for patients with behavioral health in the emergency department? And 3 major categories of concerns arose fairly quickly, and there was a lot of overlap in the conversations. That is establishing safety, initiating high quality and timely care for our patients, and maintaining flow for their emergency department setting. And we'll talk some about each of these categories. First, we'll start by talking about safety, and this pertains to both patient safety and staff safety. So as the last three psychiatrists spent time talking about, agitation is a common presentation to the emergency department. Patients are triaged in the emergency department based on acuity, and often because of the safety concerns of patients with agitation, patients are triaged and quickly and are seen quickly. What is important for us as psychiatrists to remember is that as patients are coming into the emergency department with agitation, these symptoms are undifferentiated. And what I mean by that is that they may be caused by primary mental health, substance intoxication or withdrawal, or a medical etiology that of course may represent a life-threatening condition, significant morbidity and mortality if not identified quickly. So after the ABCs are stabilized, if appropriate, a very focused evaluation occurs quickly for these patients, again, looking for red flags of medical etiology. Concurrently, at the same time, medication is usually started in order to treat the agitation, the symptom. And again, what this means in practicality is that little information is known about the underlying etiology to guide treatment strategies. As the other psychiatrists have mentioned, often, unless the diagnosis is clear, which is again uncommon, decisions are made based on route of availability and time to onset. Of course, treatment strategies may be tailored if we know the patient has a primary mental illness, substance intoxication, or withdrawal. But again, often treatment is initiated with little clinical information. In addition, staff safety concerns are paramount in the emergency department. As we are all likely aware, the environment of care of an emergency department is not ideal to take care of behavioral health patients and definitely represents a risk for agitated patients or patients with behavioral dysregulation. Because of this, this is a healthcare setting with high rates of violence in the workplace. In 2018, over 3,500 emergency medicine physicians were queried. Over 50% of them reported that they had been assaulted at work, over 60% in the last year. In 2016, a group of over 100 emergency medicine residents have been queried. 66% reported being assaulted during their training, and a very concerning under 17% had reported receiving any treatment in violence prevention. So once the patient is stabilized and it is safe to initiate psychiatric assessment and management, this can also be a challenge point for our emergency medicine physicians. Even pre-pandemic, access to psychiatric expertise was difficult to achieve in the emergency department. There have been many reductions in inpatient psychiatric beds, a dearth of trained mental health professionals. And again, the pandemic has also added a layer of challenge to our community mental health partners in being able to maintain access for individuals seeking new mental health services and ongoing psychiatric care. So as we mentioned before, patients are seeking treatment in emergency settings, and the emergency medicine docs don't have a lot of training, of course, in mental health assessments and management. So in order to fill this gap, hospital systems have created multiple different strategies to bring emergency psychiatric expertise into the emergency department. This is a picture of Unity Center for Behavioral Health where I work. We are a freestanding psychiatric facility. We have a psychiatric emergency service, which allows for 23 hours of symptom stabilization, crisis stabilization prior to disposition decisions. However, we are licensed as an emergency room under our partner medical ER. However, that ER is located a mile away. Other hospital systems have co-located or adjacent psychiatric emergency services or rooms to their medical ER. Other models, of course, have consultation psychiatrists see patients in the ER. Some emergency rooms have embedded mental health professionals. Increasingly, however, telepsychiatry has been utilized to help fill this gap. Freeman and colleagues in 2020 looked at the prevalence and use of telepsychiatry in emergency departments and found that over 20% of emergency departments use telepsychiatry for emergency psychiatric expertise. And in a follow-up study, 59% of those ERs said that emergency psychiatry services were solely based on telepsychiatry. And again, I highlight this as an additional challenge that our emergency medicine colleagues experience trying to take care of our patients. Hospital flow is not necessarily something that we spend a lot of time in CL psychiatry thinking about or training about. However, I would state that it is really essential as we think about this conversation. And flow in an emergency department really basically means the emergency department's ability to keep patient access open for new people who are coming in crisis. And what that really requires is that patients are able to transition out of the emergency department to other parts of the hospital, including the ICU, medical surgical floors, psychiatric hospitals, or discharging to outpatient level of care. The Institute for Healthcare Improvement defines hospital flow as ensuring that the patient receives the right care at the right place at the right time. The IHI does also identify that when hospital flow is impacted, there can be problems with quality of care, patient experience, and also this can contribute to burnout in the clinical team. And we'll talk some about that in a moment. Two major categories of interface with psychiatry can challenge flow in an emergency department, and that is the process of medical clearance and also psychiatric boarding. Once a patient has been determined to be appropriate for inpatient psychiatric hospitalization, the process of medical clearance is to help confirm that a patient's medical complexity is able to be managed in an inpatient psychiatric facility. That being said, medical clearance in and of itself is controversial both in practice and in the literature. In order to help clarify, the American Academy of Emergency Psychiatry came out with a consensus statement on what medical clearance entails. First and foremost, and I think very importantly, they advocate to not use the term medically clear, but rather medical stabilization in order to receive care in a psychiatric facility. And that is because our patients do not ever really truly clear all of their complex chronic medical conditions, but rather we need to make sure that the patient's conditions are able to be taken care of in psychiatric facilities, which in general are freestanding. They recommend that all mental health patients receive a medical screening exam, vital signs, a physical examination, some assessment of their mentation and cognition. If those are abnormal, they recommend further medical evaluation. They recommend in individuals who are 45 and older with no prior psychiatric history that those individuals do get further medical evaluation. Individuals 65 and older are also a high-risk patient population, and they recommend that those patients receive further medical evaluation. However, they do not recommend, for instance, if a 35-year-old with a history of paranoid schizophrenia presents off of his medications acutely paranoid, that person would get a further medical evaluation. A few other points that I think are really important for us to think about. They advocate for hospital systems of emergency departments and psychiatric hospitals to develop collaborative protocols identifying high and low risk patient populations. They also recommend that if there is disagreement at the patient level, that the two services come together and talk about how important is it really to obtain these labs. And that gets to my last point. They recommend that emergency departments do honor the request of psychiatric facilities to obtain labs. However, I think this is a real tension point and is what likely contributes to some of the flow abnormalities. We all know how difficult it can be to get phlebotomy from some of our patients who are acutely symptomatic. And so what they do recommend is if the patient is otherwise medically stable, do not delay transfer of care to the psychiatric facility while awaiting labs. So in addition to the process of medical clearance, another contributor to difficulties with flow in the emergency department includes that of psychiatric boarding. And psychiatric boarding certainly existed before the pandemic, however, has been made worse in the setting of the pandemic. This is a picture in the background of our psychiatric emergency service. Pre-pandemic, of course, nobody is masked in that picture. However, what has remained consistent is that patients continue to receive care in recliners. One of our strategies to minimize the risk of an outbreak in our PES has been to socially distance recliners. What that means, however, is we have had to limit the maximum amount of capacity of patients that we can take care of in that care environment. So social distancing and physical distancing has impacted a maximum census in psychiatric facilities. In addition, some facilities have had hospital virus outbreaks themselves. Some hospitals have made the decision to repurpose psychiatric beds to care for patients with COVID. Some hospitals have had financial struggles and have had to close their beds. And of course, most recently, our hospital systems nationwide are struggling with staffing shortages. And this has certainly become relevant in our hospital system, where many of our adult inpatient units have had caps because of lack of staffing. So in addition to all that I've talked about, there has also been the experience that some people are identifying as the politicalization of healthcare. A few weeks ago, media reports were highlighting a story occurring out of Medford, Oregon. At that time, Medford, Oregon, which is a city in Southern Oregon, was having some of the highest rates of new cases of coronavirus in the country. And within around the same time period, there were also reports of protests outside of these hospitals, protesting the vaccination mandates for healthcare workers. And one can imagine the difficulty of the experience of the healthcare workers who are trying to provide care while they're listening to the sounds of these protests. And what a contrast that must be to how these individuals started working at the beginning of the pandemic, when they were being identified as heroes and were listening to cheers and pots and pans. So you can imagine that this is a stressful environment to work in addition to ongoing coronavirus surges in the setting of staffing shortages. Many healthcare workers have children at home and children who are not eligible yet for the vaccine, ongoing concern for the healthcare workers to have breakthrough cases despite being vaccinated. So you can imagine that the burnout and demoralization in these care environments might be high. Galano and colleagues recently published a paper in August 2021 asking that question. They looked at healthcare workers who worked in both ICU and emergency departments and found concerning and perhaps not surprising rates of high rates of burnout in these healthcare professionals, 51.7 to 57% for providers, higher for nurses. The authors also highlight that these are settings that have high rates of burnout even pre-pandemic. So how do CL psychiatrists effectively insert themselves to be helpful and deliver high quality patient care to patients seeking services in the emergency department and also provide support to their colleagues? Well, I would state the most important fundamental principle is to establish a relationship based on clinical trust as the foundation of delivering high quality care. Dr. George Murray, who is our CL Fellowship Director at MGH, wrote in a communication article that to be an effective CL psychiatrist, you have to, quote, make it on the street. And to me, that meant that you have to put in the time and effort and work alongside your colleagues in order to gain their trust, in order to deliver excellent care. In addition, we should complete consults that are timely and practical. Dr. Murray also stated that we should follow our patients until they're either improved, discharged, or deceased. So again, really advocating that we work alongside our colleagues, especially during these stressful time periods, to take care of our patients. I want to highlight my point around practical consultations. I think this is really important. Many of the EM doctors that I spoke to really highlighted the fact that they have had little training in psychiatry and behavioral health. So make sure that the recommendations that you put in your notes are things that they understand, that they can engage in an informed consent process with the patient, since they're the ones often doing that. Use a patient-centered language in your consultation notes that the emergency department medicine physicians can also utilize and when they're working with their patients. When there's disagreement or difference of opinion around diagnoses or treatment strategies, create opportunities to talk about it with your colleagues. So perhaps the agitated patient, remembering again that the patient came in with undifferentiated syndrome that the EM doctors were hoping to try to stabilize as quickly as possible. Perhaps they saw something different in the presentation than you see as a CL psychiatrist after initial treatment has been rendered. Another tension point in the emergency department is the suicide risk assessment. I think especially when CL psychiatry makes recommendations for a patient who presented with suicidality that they are safe to discharge, this can be a point of discomfort for EM doctors. Spend time to understand how the patient presented when they initially came in. Maybe the EM doctor has some clinical information that you were unaware of. However, another really important strategy is to spend time educating them on how to conduct a suicide risk assessment, about the legal constraints perhaps in the states that you work in with regards to when you can provide involuntary treatment. Utilize shared language, especially in the development of collaborative protocols. This is something that AAP recommends and something that we did a lot of work on as we were opening up Unity and continue to do. When we were developing our own medical inclusion and exclusion criteria, the medical directors of our emergency department, of our emergency medical services, of Portland Police, our community partners were at the table helping us create these protocols. We've continued to meet on a regular basis We've been able to expand our inclusion criteria, again, mainly because of support and success in implementing these protocols with our colleagues. I think as CL psychiatrists, we are very good at identifying patient-level priorities, perhaps less savvy at developing or understanding system-level priorities. Understand what this means for an EM psychiatrist, or excuse me, an EM physician, when they talk about data, for instance, the left without being seen data, the door to doc data, the ambulance divert time, the percentage of ICU bed capacities being filled, the average length of time for psychiatric boarding. This helps you understand the environment that your EM doctors are practicing in and helps you be a really effective CL psychiatrist. Perhaps on a day when the ER is on ambulance divert and the ICUs are full, that's an important day for you to come down to the emergency department, see patients alongside your colleagues, and work on disposition plans. Educate, participate in educational opportunities. We've identified several already. Even something like how to form an effective consultation would be helpful for our EM colleagues, how to do pharmacology around depression and anxiety for patients who are going to be discharged, the differential diagnosis for agitation, our treatment strategies, perhaps reviewing the lectures that my colleagues have presented before. But again, spending time educating, I think, is really a benefit to them. Each of the EM doctors that I spoke with talked about they would welcome broadening the tools in their toolbox, and we can be a really important part of that. Working in an emergency department can be associated with high-risk decisions. Certainly, if there are opportunities to engage in QI and case reviews, do participate. Both of the departments and services will learn from each other in order to continue to develop improvement processes to improve patient care. And lastly, remember that as the New England Journal of Medicine talked about in 2020, we are in the midst of trying to prevent the parallel pandemic of clinician burnout. This is the time to spend time in the emergency department, taking good care of our patients, of course, being mindful and taking good care of yourselves, and also of taking good care of your colleagues. A special thanks to a group of emergency medicine colleagues who helped me create the content for this presentation and my bibliography. Thank you very much for your time and attention.